evening and welcome everyone, both here in the room as well as on Zoom. My name is Dr. Tracy Fassavino. I'm a professor here in the School of Nursing in the College of Behavioral Health and Social Sciences. And I'm super excited that you joined us for the TIDE Conference 2023. We have an excellent two speakers that are going to be sharing their passion and their hearts with us. And I really look forward to some of the Q&A afterward so that we can have some rich conversations. I want to introduce to you our first speaker, Dr. Smith Heavner. He is a registered nurse of 15 years and has had clinical practice and is a public health scientist with expertise in data science, as well as biomedical informatics and health equity. In fact, in 2021, Prisma Health honored Dr. Heavner with an award of excellence in nursing for the 7-year leadership that he was involved with the Pride Alliance, a business resource group working to improve the experiences for LGBTQ+ patients, families, and their team members. Dr. Heavner earned a PhD in applied health research and evaluation from Clemson University. Really excited about that, and is a member of the 2023 cohort of Global Clinical Research Scholars at Harvard Medical School. Dr. Heavner is the scientific director for the Cure Drug Repurposing Collaboratory. You'll have to share more about that with us too, right? A private-public partnership with the Food and Drug Administration and NIH National Center for Advancing Translational Sciences. I am super excited to welcome him to the podium to share with us his passion. Come on up, and thank you.
All right. Well, thank you very much, Dr. Weston, for that warm introduction. I do appreciate some interaction. So those of you that are with us online, I know we'll have a Q&A period later on, but don't be shy. I promise it's not that hard to derail me. So if you just want to distract me and talk about other things, I'm perfectly used to that. My classes usually try to derail me as I go through things. But as Dr. Felsen said, I'm Dr. Smitty Heavner. Please feel free to call me Smitty. Title of my talk today is Making Healthcare Fabulous. This is a talk that I'm adapting from some of that work that I did with the healthcare systems here locally, training nurses and physicians on health disparities in LGBTQ patients. And I'll talk a little bit about objectives and where we're going to go as we move through that. Well, it looks like the clicker stopped clicking. Maybe next slide, please. All right, so there's some more information about me. I do use he, him, and they, them pronouns. As Dr. Fluston said, I practiced clinically for 10 years. I stepped away from the bedside a little bit before COVID hit, and I've earned my PhD here. A little bit of clarification about what I do. I do hold that director position inside Cure Drug Repurposing Collaboratory. And what we are is a private nonprofit company that works with the FDA to explore how drugs are used off-label. And primarily, we are building tools to leverage data from the electronic health record to conduct observational studies so we can build better hypotheses as we move forward into time. Happy to talk more about that after this. It's like the focus of my talk today. My expertise is in evaluation science, but my current work is broadly in informatics. If we go, well, I do hold an adjunct assistant professor slot here at Clemson, but also at the School of Medicine in Greenville. Next slide, please. I don't have any disclosures to make other than to say I am not speaking on behalf of the FDA or the NIH, and that's just something I have to disclose just because of my position in a partnership with them. But no financial disclosures to make about this talk. So our objectives today. I'm going to talk with you a little bit about sexual orientation and gender identity, define a few key terms. We're going to talk through it very briefly just to kind of make sure we're all kind of on the same page. We're going to talk briefly about the history of LGBTQ+ healthcare. We're going to talk about a lot of the disparities. Most of our time together, we're going to talk about disparities that are impacting these groups. And then I'll wrap up by talking a little bit about what we can start to do to address them. When I give these talks, I always like to start by kind of doing a little bit of level setting. There's a lot of political tension around gender identity and sexual orientation. There's a lot of opportunities for these kinds of conversations to get very heated. For those of you that don't know, James Baldwin was a contemporary of Martin Luther King. He was part of that movement that helped plan, along with Baynard Rushton and a number of other advocates. He's a quite prolific author, but this is one of my favorite quotes of all time. We can disagree and still love each other, so long as your disagreement isn't rooted in the denial of my humanity and right to exist. In other words, we're not worried about how people feel about this topic. We're not worried about how we vote, how we practice religion, if we practice at all. We're talking about human beings and the realities that are impacting them. So welcome any questions or comments, but that's kind of the foundation of how I want to approach this. So, sex and gender. I do tend to walk back and forth, so if I get too far away from the microphone, please let me know. So, you've probably heard a lot over time about sex and gender. And we think of these as neat little categories that people can fit into, that people have an identity, that we can define that identity, that we know what's going on. It is so much more complicated than that. And as I'll talk about in a minute, we're just starting to scratch the surface on all of this. But broadly, there are 5 categories that we think of. There's my gender identity, it's how I think of myself internally. There's my gender expression, which is how I present myself to the world, how I dress, how I interact with the world, the roles I take in my environment. And those may or may not line up with my assigned sex at birth. So when you're born, the doctor pulls you out, they look at you, hold you up to the light, and they say, congratulations, it's a boy. Congratulations, it's a girl. Based purely on the anatomy between our legs, the external secondary sex characteristics. There's no genetic testing, there's no internal imaging, nothing. It's purely based on what the doctor sees. There's lots of problems with that. We'll talk about it in a minute, but we have to recognize that this is something we're assigned. And based on that decision, we're expected to fit into a lot of roles. And culturally, we may not line up with that. We may want to take care of the house. And in Western societies, if I'm assigned male at birth, that's not a role that I've traditionally accepted to be able to fill. And we have to combat against that. Those 3 constructs together kind of form our gender identity. I might be cisgender, meaning I identify as the gender I was assigned at birth. I might be transgender. I might be non-binary. I might be agender. There's lots and lots and lots of terms. As far as sexual orientation, there is my romantic attraction, there's my physical attraction, there's my emotional attraction, and these are all separate, interacting. I can have strong emotional attraction to people without any sexual activity at all or sexual desire. I can be aromantic and have no emotional connections either. And all of these are very individualistic. There's lots and lots of data out there to talk about how we can identify people broadly at the highest level. The most important thing is when someone tells you how they identify, you find out what that means for them and you honor it. There are also pronouns, which I skipped as part of our gender identity. In my introduction, I introduced myself as using he, him, and they, them pronouns. I identify as a non-binary person, but it doesn't bother me to be perceived as male, so I'm fine with using both. And we can have a whole other hour-long lecture about pronouns, but we're here to talk a little bit about disparities. Before we get into that, just to help us understand how complex this is, you've probably heard the talking point that it's simple biology, we're male and female. Nothing could be further from the truth. There are actually 6 distinct genetic makeups that are present in humans that survive to birth. There are several others that the fetus generally doesn't survive pregnancy, but even the classic XX, female, XY, male, doesn't always line up. Remember I mentioned we don't check the child's genetic makeup. There are situations in which someone can appear outwardly female but have XY. And that happens because we all start out as female, we all have nipples, the clitoris develops into a penis. All of that happens because the body is exposed to testosterone. But if my body isn't sensitive to testosterone, I'll never develop those characteristics. And I might be assigned female at birth. And regardless of my gender identity, whether I align with that identity, Those patients sometimes find out later when they're trying to conceive, they go through fertility testing, and it turns out they actually had testes instead of ovaries. A number of other configurations that can happen. Some don't, particularly the last one, XXY, those patients tend not to survive too terribly long, but there are three others, Klinefelter syndrome, Turner syndrome, and XYY, that are not infrequent. Those seem like pretty rare conditions, but out of 1,000, having one case, that's a lot of people. I'm sure you have classmates that have these conditions. So why does this matter? Why do we need to talk about this? The reality is there's a lot of research that still has to be done. What we know about gender and sexuality is quite recent. We could look back at the history of queer people all the way back to Mesopotamia. We could talk about the depictions of intersex people. We could talk about the concept of two-spirit in Native American traditions. But prior to modern Western civilization, this idea of a sexuality didn't necessarily exist. And it's a whole other historical anthropological conversation, which is not what we want to talk about with you today. But really, we start getting our modern conception in the late 1800s. In 1886, we see the first publication of a study that looked at probably what is the modern concept of homosexuality. This is was very vague, very high level, lots of problems with it, as with a lot of research from the 1800s. And in 1906, we see the first modern account of modern gender affirming surgeries. You might have heard of Eli Liddy. The movie The Danish Girl was based on her experience. That was later in the 1920s. And we started to see this explosion of study, of research, of digging in to understand what is happening with people's identities and their orientation until the 1930s. In the 1920s, the Institute for Sexual Research, the Institute für Sexualwissenschaft in the original German, was founded in Berlin. They had a huge, amazing repository of data, of photos, of papers, of testimonies, lots and lots of research. And the Nazis came in and destroyed it. Likely that event set back our understanding of gender and sexuality by at least several decades, if not a century. And some experts would say we're just now really starting to catch up. And it's not until the 1940s that we start seeing some real empirical research into sexuality. You might have heard of the Kincer reports, the first of which were published in 1948. This is his report on sexuality in the human male. Now, if you know the history, there's a lot of problems with that research. There was a lot of potentially unethical practices that were happening in that lab, but it does start to help us get this modern understanding that there's a continuum of sexuality. It's not until 1973 that we start shifting away from an idea that homosexuality is a mental illness. And it's much later that we start shifting away from the idea that being transgender is a mental illness. At this point, there are still widespread anti-sodomy laws on the books. So this timeline does not include any of the major political events. But this moment when the American Psychoanalytic Association were declassified from mental illness, it's still classified as a condition. There's still lots of others, but this is the first time a major medical association starts to say, wait a minute, there's nothing wrong with these people. They just have a different experience of the world. And then it's not until 1993 that we see the first publication indicating a genetic influence in sexual orientation. For some of our students here at Clemson, that doesn't seem like it's very recent, but I've reached the age where that is very recent. That's only 30 years ago. And it's not until 1995 that the first treatment for HIV is approved. And now the AIDS epidemic started in 1981. And so it's 14 years that there's a lack of funding, there's a lack of resources, a lack of time being spent to study a disease that's primarily affecting men who have sex with men, where we finally get a breakthrough treatment. In 2013, the National Library of Medicine added homophobia as a medical subject heading. And that is significant because that means we are starting to see enough volume of research around the concept of homophobia that there's a need to catalog it independently. And so starting in the 1980s, men who have sex with men were banned from donating blood. It's not until 2015 that men who have sex with men who have sex with men are allowed to donate blood, but at this time, they had to be celibate for a full year. Prior to that, if you're a man who had ever had sex with a man since 1983, you weren't allowed to donate blood. Through COVID, that's now been reduced to 3 months, but you still have to be celibate for 3 months. And we'll maybe touch a little bit more on that, but this is just a timeline to show it's not until very recently that we start seeing major movements to destigmatize gender and sexuality in medicine and healthcare. So why does that matter? Stigma and bias are pervasive throughout everything we do. There are structural stigmas. We might see something about an institution causing a problem for gender identity. Having a gendered bathroom is an institutional bias where someone has to make a choice where they go. I don't know about y'all, but I tend not to interact with other people when I go to the bathroom. But it's a fairly straightforward process to make things more gender neutral, provide a gender neutral option. But if an institution doesn't provide that, it's an immediate signal that this is not a welcoming environment for people who don't fit neatly into one category or the other. Sometimes this is overt, sometimes this is very intentional, sometimes it's malicious. But more often than not, it's due to something called unconscious bias, where there's an idea that we have in our head that ends up guiding our ideas, how we interact with the world. That might be something fairly innocuous, like thinking a gay man should have a keen sense of fashion. Or it might be something a little bit more insidious. For example, clutching a bag a little bit tighter when the person of color walks past you on the street. There's a link there, projectimplicit.net, where you can actually learn a lot more about implicit bias and even take some testing on it. And it's really effective and really helpful. I strongly encourage everyone to do it. But rather than dig into that, since I only have probably 15 minutes left, I want to talk about why that matters. So when we have a system where there's this constant pervasive signaling that LGBTQ people are not welcome, when all the offices have very gendered restrooms, when all the medical forms are very insistent on using very heteronormative language, you end up in an environment that actively discourages people from seeking care. You end up with them not sharing as much information with their provider as they should. You also end up with a situation which is causing perpetual stress for the individuals, and that can lead to worse health outcomes. One really clear example that we've recently really come to understand, when I was training in nursing, they taught me that African Americans were genetically more likely to have hypertension. And that was universally accepted fact. Tom's nodding at me because everyone accepted that. Up until recently, we've realized that's not the case. It's actually the culture, the stress, the generational trauma, living in constant fear of the police that is adding to that. Now, there are biological factors. We know there are some medications that help African Americans treat blood pressure more than others, but we've allowed this bias to just completely overtake how we take care of these patients. And we're just now starting to understand how much that's happening in other areas. That's one example where we really clearly understood. It also influences the care of renal failure, and a whole long clinical lecture on that. But as these patients fear being discriminated, they're just less likely to go to the doctor. They're also less likely to listen to the doctor. If you're talking to someone that you think doesn't respect you, you're not going to take their advice seriously, right? So what happens from here? And why does this persist? Why do we keep seeing this? And it boils down to a complete lack of education. In the United States, in medical schools, most medical schools spend less than 5 hours discussing LGBTQ patients. When LGBTQ patients are discussed, or they're presented in the standardized patient or simulation experience for the nurse, for the physician, for the PA, to learn about them, it's frequently about HIV, or it's about hormone replacement therapy, or something very specifically related to their identity. It's very rare in those simulations that it's this patient, John, and his husband are here, and they're worried about John's blood pressure. That's not how the case is presented. So you end up with providers that when they hear that someone is queer, they zero in on those issues. And I can illustrate this with a personal example. A number of years ago, I went to my primary care provider, And doing a general checkup, needed to update my medicines, check my blood pressure, my cholesterol, all of that. Well, my nurse practitioner started talking to me about PrEP. It's pre-exposure prophylaxis, a medication that can prevent the transmission of HIV. At this point, I'd been in a monogamous relationship for 3 years, and one of the criteria for receiving PrEP is having multiple sexual partners. And I kept trying to say, like, I don't think I'm a candidate. And she kept saying, well, but you're gay, you should be on this medicine. Now, thankfully, as a nurse, I was able to kind of advocate for myself and engage and talk with her. But I'm sitting there thinking, like, I have things I want to talk about. Like, I'm overweight. I just told you I drink 6 glasses of wine a week. Like, there are other things that we could be talking about. Instead, we're focused on this one issue. Now, she had obviously attended the conference and she really wanted to make sure she was doing the best thing for her patient. But because of this unconscious bias, she assumed that I would be a candidate for this, despite me telling her that I don't actually meet the criteria. And so we wasted a lot of time. Had I not been a healthcare provider, had I not been engaged in advocacy work, I might have walked out of that office and never come back. And that's the experience. That can be how benign the experience is. It doesn't have to be something overt, someone hearing that the provider tell them that they're a sinner, that they're awful, that they're going to go to hell. It can be just as insignificant and as innocuous as just not feeling like you're being heard. We also know that public health programs tend to focus on HIV. Now, I'm not downplaying HIV, it's a big problem. And we can talk about that more too. But there are lots of other issues that I'll mention that we could be looking at. And in published research throughout all equity metrics, we end up with data that's interpreted probably not in the best way. If we're including race as a covariate, as a variable in our analysis, we shouldn't be saying African Americans have a higher risk. We should be acknowledging that there's probably more to it. There's more to it that gay men have a higher risk for HIV transmission, other than just the fact that they're gay. So this is where I'm going to ask you all for a little bit of participation. And I'm going to give you a list. But what health disparities do y'all know about for the LGBTQ community? One of the students. Anything? What can y'all think of? Diabetes? You've done your homework. Yeah. So diabetes, there's actually a higher incidence of diabetes in a lot of LGBT communities because there's also a higher incidence of obesity, right? And that may be due to the lack of care, the chronic stress. We don't really know yet. Any other ideas? Anxiety, depression. Why?
The daily stressors you're talking about.
Daily stressors. Absolutely. Anything else? I really thought one of y'all was going to offer up HIV, but I did kind of hammer on it a little bit. There's lots going on with these patients. One example that I really want to talk about is human papillomavirus, HPV. Does everyone know what this is? Getting a lot of head nods. So leading cause of cervical and anal cancer. It's introduced during penetrative intercourse. So if we're talking specifically about cervical cancer, which group do y'all think has the highest risk of being diagnosed with cervical cancer related to HPV? Any ideas?
I'm just thinking by group. Are you talking a racial group or are you talking?
Cisgender heterosexual women versus, cisgender heterosexual women versus cisgender lesbian bisexual women. Which group do you think has the highest incidence? They contract HPV, develop cancer at a higher rate.
I would think that you would find it in cisgender heterosexual women more because they're more likely to be unconscious bias getting pap smears and detected.
Well, they're more likely to be exposed, right? It's delivered during penetrative intercourse. If there's a lesbian couple using toys, you clean those between, risk goes down pretty high. But if we think about the mortality, any guesses what happens? I'm giving it away. It flips.
Right.
Lesbian and bisexual women we don't know for sure, but the current data shows they're likely to have much higher mortality rates for cervical cancer due to HPV. Now, they're a lower risk for contracting HPV, but they're much higher risk to have the worst outcome for that. And that is purely because of stigma. They are less likely to get their pap smears. They're less likely to go get their routine screening. This is true of a lot of other cancers as well. But they're less likely to catch it in an early stage. So for lesbian and bisexual women, by the time it's caught, it's because they have outward symptoms that have driven them to go to the doctor. They're not getting a routine pap smear. And so because of the bias that A, we think they don't need the pap smear because they're not having sex with someone with a penis. And B, they're less likely to go to the doctor because they're afraid of being stigmatized or treated poorly by their doctor. A few other health disparities. Most of you know about youth. Youth are 2 to 3 times more likely to attempt suicide if they're LGBTQ. They're more likely to be homeless. They're less likely to have social support, which ends up that they're more likely to be victims of sexual violence. They're more likely to be trafficked. So they have higher rates of STIs. In adults and youth, there are higher rates of tobacco, alcohol, drug use. There's higher rates of obesity, diabetes, and lesbian and bisexual women are less likely to get preventative services for cancer screening. All of this ends up at least partially coming, theoretically, from stigma. The youth don't have a support system, they end up on the street, they don't have a safe place to stay, they rely on the wrong person, they end up getting hurt. People are stressed, they don't have a good support system, they're more likely to turn to substances to try to self-medicate. Specifically here in the upstate, we've done some surveys through a number of groups that I work with. We know that 33% of LGBTQ patients in the upstate have had at least one negative experience. And there might be something fairly benign like my experience. Some of them are much more extreme. 23% of transgender people in the upstate of South Carolina haven't seen a doctor in the last year. And that's out of fear of being mistreated. We all know it's really important to go to the doctor every year. Most of us don't actually do it, but we know it's important, right? And 33% don't go to the doctor because they can't afford it. And that's another interesting interaction, and it's more complicated because for every group, except for cisgender white men in relationships with cisgender white men, their income is below the average. They make less money on average. The same cisgender male white couples are the only ones that on average do better than the general population. In rural health, as my colleague will talk to a little bit, these things get even worse. They have higher rates of loneliness and social isolation. They have poor healthcare access. There's not enough systems that are available. They don't have good choice. And those systems are not very likely to have the training to be able to talk to patients about these issues. There's also some evidence to suggest they may have a higher prevalence of chronic conditions, with a higher percentage of LGBTQ rural Americans reporting at least 3 chronic conditions versus their heterosexual peers. So what do? We've got to reduce stigma. We need to enhance LGBTQ curriculum for healthcare professionals, and we need to learn more. There's so little research out there. When I was doing my PhD, I really wanted to do LGBTQ health, but I couldn't because I couldn't find a data source, and I really didn't want to do primary data collection. But we know so little. And part of it is because there's not been large scale data collection, but the data we do collect doesn't get there. I'm sure you've heard about the realities that in a lot of studies, we only collect race and sex, that we don't dig into social drivers of health, we don't collect information. We're also not collecting gender identity and sexual orientation. In my world, looking at the EHR, that data is not available for us to include, except for a few institutions. It's getting better, but it's going to be over the next 10, 15 years that we really start to understand just how bad the situation is and how we can start to address it. I've got a few sources here in case anybody wants to read up a little more. There's just a few selected readings that I pulled from for this talk. Just a few. The 3 at the top are probably the most cross-cutting, but they cover a couple of different areas. There's lots of wonderful research about the levels of stigma and bias that we see in young physicians and young nurses, but I don't want to bore you all with a whole bunch of statistics. And I also just want to mention a local resource, the Career Wellness Center of Greenville. There's lots of community centers throughout the United States, but this is a local one where there's training, there's education, and there's support for LGBTQ youth and young adults. As y'all move through your careers, as y'all move through your education, I encourage you to think about what it is that you want, how you want to contribute, and start thinking about how you make sure this data is being used appropriately. And what are the little itty bitty ways that you can start making these a little bit better, whether that's just asking an extra question on a survey or digging a little bit deeper into an analysis to understand exactly what can be done better. But thank you.
Really appreciate you taking the time to share all of that with us. Our next speaker is Dr. Kincer from East Tennessee State University. We're very excited to have him here. He is the Associate Dean for Rural and Community Programs at the James H. Quinlan College of Medicine in Johnson City, Tennessee, which is where I hail from. He was born and raised in Eastern Kentucky, giving him the firsthand knowledge of the education and healthcare needs of the Appalachia region. He attended Berea College and then the University of Kentucky College of Medicine. Upon completion of his residency at UAB, he began his lifelong academic career. He served early in his career as a faculty in Kingsport and then as the program director in Montgomery, Alabama, for the majority of his career. But he returned to East Tennessee State University and serves as the Associate Dean now, and we're super excited to have him here. He's really working to recruit and train medical students for the rural and underserved communities for our region, all through the Appalachia. And he really enjoys, I know, having spent time with both of these wonderful presenters today. I just realized you're really tall and he enjoys being active. He enjoys doing the running, and we're really excited to have him here to share with us some of his background and his thoughts on rural health. So I'll turn it over to him.
Thank you. All right. Thank you again, Dr. Fasolino, for the invitation to be here. Greetings from East Tennessee State University. This is my first time on the Clemson campus, and let me tell you, it is absolutely gorgeous. I just love being here today. We've had a wonderful day, and I appreciate being here. And also getting to know Dr. Heavner today. And what a wonderful, wonderful talk you just gave. And I can't thank you enough for that talk. So thank you very much. And we'll probably tie a little bit into from your talk into mine today. So my talk today is Rurality as a Global Health Concern. I know that a little bit of the conference today is geared towards global health, and I want to present to you some ideas about rurality being a global health concern. I would like to introduce you to John and Molly Niswander, good friends of mine, and I will get back to them a little bit later, and you will see how they tie into this. I do have a lot of slides and not enough time to go through them, so I will skip through several. We know about disclosures, objectives, and I'm going to talk to you today. But I want to start out with a couple of patients because we're going to talk about health disparities. Dr. Heavner mentioned disparities. He did a great job of telling you what disparities are. And then I will introduce what we call health inequities, how people that experience these disparities don't get the same treatment. And inequity says that under similar circumstances, two people are not treated the same. And by not being treated the same, they have different outcomes. A disparity could be thought as a regional, an ethnic, a racial issue, whereas a health inequity is a social issue. It means that we haven't met the social needs of our people and we're letting them down, if you will. Let me introduce you to Cortland and Austin. Cortland and Austin are really an accumulation of patients that I have had. I'm a family physician by education and practiced for 32 years, 34 now, since I've been at East Tennessee State University. And these two patients are an accumulation of all the patients that I've treated with diabetes. Cortland, they're both 32 years old. One lives in a more urban area, that's Cortland. Austin lives in rural Johnson County, and some of you may know Johnson County right above Boone, North Carolina, above Asheville. It is a very rural community in East Tennessee. Cortland was able to get a bachelor's degree. Austin dropped out of high school, which is very common in our rural communities, setting up some disparities. Cortland now works. He has Blue Cross Blue Shield insurance. Austin works odd jobs, does not have insurance because smoking is a little bit more prevalent in our rural communities. Austin is a smoker, Cortland is not. And because Cortland has insurance, her medicines cost $14 for a 3-month supply, and Austin pays full price out of pocket. See how this is starting to set up, and it's based on location, it's based on social drivers of health. And I want to thank Dr. Heavner for using the word drivers instead of determinants, because determinants mean we can't change it. Drivers mean we can change it.
Absolutely.
Absolutely. So social drivers of health are conditions in our environment where we are born, live, work, play, worship that affect our health. And those can be in 5 domains: economic, education, healthcare access, our neighborhood, and our social context. The largest single driver is income. Now you can back that out and you can look at what determines income, education, where you live. If you're in Johnson County, you can have a PhD or an MD and you may not make a lot of money because there may not be a lot of work there for you. So it's not just education, but that's the first place to start looking. But income is the largest social driver. A map of Appalachia, you can see how it extends from New York all the way down in through Alabama into Mississippi. The red on the map are what we call highly distressed regions. Not every region of Appalachia is equal. The red is highly distressed areas, and you can see Kentucky, and the eastern section of Kentucky is the most red, and that's my home. That's where I grew up. And it is still distressed. Back in 1965, President Lyndon B. Johnson formed the Appalachian Regional Commission, and they've been in there for almost 60 years, and they've made a little progress, but not nearly enough. A couple of weeks ago, I was up visiting my cousin who lives in St. Paul, Virginia, which is in that distressed region in the western tip of Virginia, and we went to a little town. He works on the railroad. And we went to the little town of Dante, Virginia. Now, it is spelled Dante, but you do not say Dante if you go there. You got to say Dante, because if you say Dante, they know you're not from there. And at that point, but you know, back in the 1920s and 30s, Dante, Virginia was a thriving coal company. Today, Dante, Virginia probably has 180 to 200 people living there, and it's abject poverty. The coal mines left. Some people stayed, and it's abject poverty. We drove through there because he had to do something on the railroad, and it still runs through there, but it doesn't stop in Dante anymore. The houses are dilapidated, and the windows can be broken, and you think no one lives there, but that is still their home. It is an awful situation to see. If you ever drive through there, your heart would just reach out to these people. There's no way that it couldn't. Remember that I gave this talk, I gave this slide to Dr. Fasolino a couple of months ago, but I was just in Dante, and it brought it up that I need to mention Dante in my talk. So this is where I grew up. I'm standing on the top of Pound Mountain looking over. You can see the little community down below there. You can see the mountains in the background. This is a little community called Jenkins, Kentucky, in Letcher County, Kentucky. This is my stomping ground. This is where I grew up. And you may not see this, but right in the middle of this slide, you can see the roof line of a house and a little railing on the porch. That's my house. That's where I grew up. Those were the first 18 years of my life, sitting in rural Appalachia. I am the living being of rural distressed Appalachia. I was very fortunate that my father said, son, you're going to get out of here and you're going to go to college. If it weren't for that, I would probably still be living in Eastern Kentucky, living in one of these distressed regions, not having a doctorate degree, and not being here talking to you today. But that's my house. I look on it fondly, and I love Eastern Kentucky. Often we think when we hear distressed regions of Appalachia, we get that unconscious bias that everyone there is living in abject poverty, but they're not. It is a wonderful place to live. The mountains are gorgeous. And if you have the means, you can have a good life there, but you have to know how to live around it, if you will. Education systems are poor. You have to understand how to live there if you're going to, but the people are wonderful. They will do anything for you. And a lot of times the people don't even look upon themselves as being impoverished or having the distress that we can see if you've been there and you're not from there. It was an old coal mining community. These are coal houses. You can see when the coal mines ran away, what happened to the houses. They just go down, and you can see that there's a little pile of coal sitting out beside this house because people still heat their house with coal. And someone lives in this house. They believe in God and America. You can't see it, but there's a Christian cross, if you will, on the side of the front porch there, and an American flag waving in the background. But they are very impoverished. This is a home where I went to high school, Fleming Neon, Kentucky. Population in 1940 was about 1,200. A couple of years ago, it was less than half of that, and now it's even less because in the summer of 2022, you may have heard about it. There was massive flooding in Eastern Kentucky, and this entire town was wiped out. It no longer exists. Does not exist. Every one of those stores are gone. At the very end of that street up on the hill, you see a school. That's where I went to high school, Fleming Neon High School. This is the flood. The little girl sitting on top of that is one of my distant cousins. She is sitting on the top of her house. She was able to climb out of the window. She has her little dog in her lap, and she sat there and waited for someone in a boat to come by and pick her up. Back to Cortland and Austin. Cortland's hemoglobin A1C, that's how we measure diabetes, is 7.2. That's not bad when she is found just on an annual exam, but that is diabetes. Anything above 6.5 is diabetes. Hers was found on a screening exam. Now, Austin, he's out working. He doesn't get screening exams. He passes out in the hot summer sun, and they take him to the emergency room, and his hemoglobin A1C is 11.8. His ER bill is $3,200, no insurance. Cortland's BMI, 31. Doctor advises her a low concentrated sugar diet, increased activity, nutritional counseling. Counseling gives her one of the best medicines on the market for diabetes. It's $943 a month, true price. She only has a $30 copay. Austin goes to the ER. They give him some fluids, give him some insulin, get his sugar down, they send him home. He doesn't have a doctor. He doesn't get medicine. He goes along his way. Poverty. Appalachia. You can see the dark blue is the most impoverished area with a poverty rate of as much as 41%. 41% poverty rate in the same areas on the other map that were red. Distress and poverty go hand in hand. This is high school completion rate. Do all these maps look the same? Well, they do. You see that the high school completion rate is only 58 to 75% in these distressed regions. I graduated from high school in 1980. When I started high school in 1976, I had 125 students in my Fleming Neon class. We graduated 60. Graduation rate 50%. 6 of us went to college. That's why we have such high poverty rate, low education. And in the mountains of the rural regions and the distressed regions, once the coal mining industry pulled out, no new industry came in. If you've ever been in the Appalachian Mountains, it's hard to put industry between two mountains. There's no place to build anything. And people are left with no industry and no way to make a living. And one might ask, well, why do they still live there? And today we were having a very nice lunch today, and one of the anthropologists said, you've really got to understand people are loyal to their homeland and they don't want to leave. Today in Appalachia, healthcare, infant mortality rate 16% higher. These numbers should not surprise anyone. Life expectancy is at least 3 years lower than national average, at least 3 years, probably more. 12% fewer primary care physicians, 35% fewer mental health physicians, 28% lower specialty physicians, 26% lower dental, and cancer rates are 32% higher. Why are cancer rates 32% higher? Because diseases of despair, cancer being one of those, go back to things like smoking, drugs, alcohol, all of which are factors for cancer. Not to mention, just like we talked about in the LGBTQ plus community, they don't seek health care and they don't get primary care screenings. My uncle, my mom's oldest brother, died of colon cancer a couple of years ago. He was 84 years old, otherwise healthy, never had a colonoscopy in his life, probably would still be alive today had he got a colonoscopy. That was his only diagnosis. And it was metastatic when they found it, incurable. Substance abuse, we all know that it is very, very high in our distressed counties. Why is substance abuse so high? Again, diseases of despair. If you don't have a job, you don't have anything to look forward to, you look towards drinking drugs and alcohol to fill the time. It's a distraction. It's a way of treating depression and a way of treating anxieties. Sadly, it's the wrong way to treat it. And people die from overdose. But they're self-treating, self-medicating depression. We can get into the biology of depression with the serotonin receptors and norepinephrine. And one of the key ones, and we don't think about it, is the mu receptor. And that's where opioids bind. And here's the thing about people that get addicted to drugs. You can tell by asking one question whether this person's going to get addicted to a drug. When you took that narcotic, how did it make you feel? What's somebody that's going to be a drug addict? What is their answer? Want to give a guess? Normal.
Normal.
It made me feel normal. For the first time in my life, I felt normal. They didn't feel high. They felt normal. Because just like we give SSRIs for depression, and it binds to those serotonin reuptake, the mu receptors are also a one way to treat depression. And if you treat that with an opioid, they feel normal. But unlike SSRIs, with opioids, you develop a tolerance. And you need a little bit more to still feel normal. And you need a little bit more to still feel normal. But the respiratory depression doesn't become intolerant. And then one day, just trying to feel normal, you take a little too much and you die. That's why we can't treat depression with opioids. Back to Cortland and Austin. Cortland went to a nutrition educator, no cost. It was right there in her hometown of Knoxville. Insurance paid it all. She's tolerating her injections. She's now exercising. She has the money to pay for the gym, which is close to home. She lost 15 pounds and her hemoglobin A1C is now 5.8. She's normal. Poor old Austin didn't seek any further medical care. He had no money, didn't go to the doctor, didn't have a doctor, went to it. The nearest doctor is 25 miles away. It's an FQHC. We talked about FQHCs today. It's a federally qualified health center that gets subsidiary income to help treat people who don't have insurance. His finger stick blood sugar was too high to read. He was prescribed metformin and glyburide, good medicines, but not nearly as good as Cortland got. They cost $12 at your local pharmacy. Closest he could get to any diabetic counseling was an hour away and it cost him $250. He didn't go. If we look at life expectancy, we can see that if you live in a large metro area, your life expectancy is much higher than if you live in a rural, non-metro county, for all the reasons that we've talked about. I will not recover those, but understand that rurality itself is a social driver of health. Are you starting to see a little bit of comparison to what we normally and typically think of as global health? Considerations for accessing healthcare. And we can say in rural areas, but this is in a lot of areas. Financial means, scarcity of providers. You don't have as many doctors in rural communities. Why? There's not a lot to draw doctors back to rural communities. We know that if you're from a rural community and you become a healthcare provider, whether you're a nurse, a doctor, a PA, pharmacist, you're more likely to go back to that rural community. But it's still only about a 40% chance that you'll do that. Transportation, inability to take time off from work. A lot of people that work in rural communities work in jobs that they can't take time off. There are no vacation days and they live paycheck to paycheck. And if you take a day off, how am I going to pay for X or even get fired for taking a day off? Communication abilities. We're not even going to try to cover the health literacy, but communication is a big issue. Trust is a big issue. A lot of people in rural communities don't trust easily, and you've got to develop that trust. We talked about medical literacy and then just a perceived need, or one might call that denial. I don't need to go to the doctor, I'm fine. If this will get better. Back to Cortland and Austin. She sees her physician twice a year. BMI has been stable at 27, which is almost normal, better than it was. Still exercising, hemoglobin A1C still runs normal. She still does well, has normal exams, no health issues. Austin sees a doctor when he can afford it. Transportation, not so dependable, still doesn't have insurance, takes medicines when he can afford them, but mostly when he just feels bad. Here's the key. Too many other factors to worry about before his health. I've got children to feed. I've got to pay my electric bill. I'm behind on my rent. My car needs to be fixed. Who has time or energy to go to a healthcare provider? I just don't have time to do that. Last hemoglobin A1C done 5 months ago was 9.8, and now his feet are starting to burn a lot, which means that his diabetes is starting to kill the nerves in his feet. We all talked about the Affordable Health Care Act. Good ideas, mean well, tried to fill gaps, succeeded initially, but we've done a lot of backsliding. It's not filling the gaps as we thought it would. It's still unaffordable and unattainable for most people. Uninsured rates among the non-elderly by state. Why non-elderly? Because when you're 65 and above, you get Medicare, so you have insurance. But below 65, you have to pay for it yourself, or you get on Medicaid. And there's a lot of states that did not expand Medicaid, and I will not get into the political ramifications for that, but you can look at this colored map and determine for yourself which states expanded Medicaid and which states did not, based on the uninsured rates. And if you're uninsured, the likelihood that you're going to get the care that you need is very low. And you can see that in the Appalachian region, we have some of the most high uninsured rates of all. Reasons: not affordable, not eligible, don't need it or don't want it. I don't really understand don't need it. They need it. The don't want it probably falls back up there and can't afford it or not eligible. Signing up was too difficult or confusing. In Clemson, in Johnson City, I'm sitting here looking at a computer. In Johnson County, which is not Johnson City, it is an extremely rural area, and only 40% of the entire population of that county has broadband internet. How can you sign up for anything if you don't have internet? And can't find a plan that meets your needs, lost your job. We talked a little bit about FQHCs, Federally Qualified Health Centers. They get reimbursed at a higher rate to be able to help patients that don't have insurance be able to afford insurance. And they have filled numerous gaps, but there's not enough of them. And there's not enough providers willing to work at an FQHC because FQHCs typically can't afford to pay what the local hospital can pay. And when you're looking at having to pay back college loans, medical student loans, it just doesn't work out financially. And so a lot of FQHCs are struggling to find providers. And the National Association of Free and Charitable Clinics, we have the TCCN in Tennessee, which is the Tennessee Charitable Care Network, and there's a lot of clinics. And through East Tennessee State University, we are so fortunate to be partners with a lot of TCCN clinics, and our medical students and our residents go and provide free health care when we can. And we see a lot of wonderful patients who are so grateful for us to be there, but the need is far greater than we can cover. Two similar clinics, both of these are TCCN clinics. They're nonprofit clinics. They depend on donations. They see the uninsured. They offer medical, dental, counseling. These are wonderful people, and I love to go there, and I love to spend my time, and I donate some of my time and go there and see patients. And I just love them, and they do a great job. We just wish that there were more of these clinics out there, and I just wanted to give them a shout out today to say they are doing a wonderful job in our rural communities. This is another called the Health Wagon in Southwest Virginia. This was started by a Catholic nun who was also a physician. She purchased a van like this back in the 1980s and started the Health Wagon, and she just drove from community to community, probably drove through Dayton. But now they have some brick and mortar buildings, and they still have some health wagons, and we work with them as well. And again, they are just wonderful people, and a good shout out to the Health Wagon. Health disparities, we talked about preventable differences in the burden of disease and injury that are experienced by social disadvantaged populations versus equity. And so when every person has the opportunity to attain his or her full health potential, at that point, we will have health equity. We can't force someone to get health care, but we can give them the potential to have health care. At this point, it doesn't exist. Revisiting our patients 10 years later, and we can see the inequities that poor Austin had. Cortland's doing fine. No secondary organ damage. Her diabetes is under control. Cortland's now 42 years old. He's now disabled. He's on dialysis due to kidney failure from diabetes. He's had a below-the-knee amputation for vascular disease. It's amazing the things we talked about today and how it's coming out in this talk. And he often misses dialysis and ends up in the hospital because he doesn't have transportation to get to dialysis. These are real patients, not made up. These are real people. I've taken care of them. I've watched Austin die before the age of 50, and I've watched Cortland live out her life. These are due to inequities in our healthcare system. I want to read this to you. This is a report to the Human Civil Rights Council from a research done in 2018 by Philip Alston. The United States is a land of stark contrast. It is one of the world's wealthiest societies, a global health leader in many areas, and a land of unsurpassed technology and other forms of innovation. We can all agree with that. Its corporations are global trendsetters. Its civil society is vibrant and sophisticated, and its higher education system leads the world. But Its immense wealth and expertise stand in shocking contrast with the conditions in which vast numbers of its citizens live. About 40 million Americans live in poverty, 18.5 million in extreme poverty, and 5.3 million live in third world conditions of absolute, and I'll throw in the word, abject poverty. Date, Virginia is a third world country. Fleming Neon, Kentucky is a third world Kentucky or country. This is where I grew up. It exists. Having never experienced anything different, you cannot see any different. And when shown different, it is so foreign to you, it remains unrecognized and is quickly dismissed or is considered unimportant. Now, back to John and Molly Niswander. When I was a little kid, growing up on that house that you saw on the side of the mountain in eastern Kentucky, John and Molly Niswander walked into my life, into my family's life. John and Molly are Mennonites from Canada. They were required by their religion to do a mission trip for 1 year. They came to eastern Kentucky. John was a craftsman, carpenter, electrician. Molly was a nurse. Molly worked at the local hospital, and John helped people rebuild their dilapidated house. My house. I didn't know this as a kid. It's my house, but it was dilapidated. It was built in around 1900. The electrical system was dangerous. The floors were rotting. It had no insulation. John came in with one of his Mennonite fellow mates, Ernie. So John and Ernie came and worked on the house, and they spent 6 months rebuilding our house. Free, not a penny, free. As a kid, I didn't think much of it. John and Molly befriended our family, and they loved the region so much, they decided to extend their mission for another year. And then off they went back to Canada. Rurality is a global health concern. We sit here and we think, I want to be a missionary. And we automatically think that we need to go to Ecuador, or we need to go to Belize, or we need to go to Honduras, or we need to go to some country in Africa. But I am here to challenge you to say that a lot of times all you need to do is look in your backyard, and you can have all the mission work that you ever wanted to have. And John and Molly traveled from Canada to my hometown to do mission work. And I never thought of that as a global health concern until now. So thank you very much for listening to my talk. I appreciate it. And I think with that, we're going to move into a question and answer session. So thank you very much.
Thank you for that amazing presentation, both of you. We do have a time now for question and answer, both on our virtual platforms as well as our audience here. I'm going to ask the guest speakers to come up if there is anything specific that you would like to ask. Certainly put it in the chat for those of you who are joining us on Zoom. We're super excited to have you here also. But I'm going to give it a few minutes to see if anybody has anything. Yes.
Can you talk a little bit, a bit more about why the affordable healthcare whole thing is still yet unaffordable, even though that's not what it was supposed to, or at least that's what they told us.
Yeah. Dr. Heavner said, good luck with that question. I think that is a large political question. You know, it went out to healthcare markets, and you could get a little bit of subsidizing to help afford it. But if you're looking at an income, if your total income is $18,000 a year, even if your healthcare is only $250 a month, that could be more than you could afford if you're trying to pay for your rent or your electricity, so it still became unaffordable for most. Sadly, that's the best answer I've got for you at this point.
And South Carolina was not a state that adopted the Medicaid expansion either, so we have a large portion of our poor and uninsured that are not getting even some of the resources that are available with the Medicaid expansion that had occurred a couple years ago. And again, it's a political, right? It's a political, a huge problem that we're facing. So we have a lot of patients who still have no insurance or underinsured, which is a term we use pretty regularly, that you may have a policy but it doesn't pay for certain medicines, like the insulin or the pumps or the ones that we know from research are more effective, but because of your insurance, it won't cover that. In my world of pulmonary, they don't pay for the really great inhalers that we know are effective for some of our pulmonary diseases. So still a problem. But that's a great question, Dr. McCoy.
Thank you for that answer. I mean, this whole topic, both of your topics I have great interest in. I'm wondering, it kind of akin to the speaker that we had before this one. The topic came up of our society being very individualistic in their thinking. And so what I have noticed is that a lot of times we're so prone to, for instance, a lot of people don't even know how to cook, let alone cook healthy. I mean, if your choice is going to McDonald's and getting $1 off the dollar menu versus cooking a healthier meal that is going to cost a little more, but you can stretch it a little bit. But what I find is a lot of people don't even know how to do the basic things of stretching a meal in today's society. Now, Tom and I assume we're a little bit in the same age bracket kind of sort of. And so maybe we have a background that lends itself, and especially with the background that Tom has, that maybe stretching a meal is something we may know how to do. However, what I see in today's time is people don't have those skills. So they're going to the store and they're picking up items that if they just learn how to cook, they could probably make a whole lot of it for less money. So I'm just curious, from both of your perspectives, how do you see present societal standards, in particular in America, that kind of work against some of the goals that we have of healthcare, both in rurality and even in LGBTQ situations?
Sure. I'm gonna sound a little bit like a broken record, but I think part of it comes back to stigma. You know, we've stigmatized poverty to the point that we view it as a moral failing of that individual. And so instead of looking at these communities from a nursing perspective, so looking at these communities as communities that have been robbed of their resources, communities that have had their industry ripped out from under them and have nothing to be able to help themselves, we tend to look at them as a society and say, well, why aren't they doing better? In LGBTQ communities, there's a lot of stigma and bias where we think, well, these are dangerous people, and so their health outcomes don't matter. And we end up with this short-sighted notion and this hyper-individualism that it's, I'm going to worry about making sure I get my piece of the pie. I'm going to make sure I know how to cook, make sure I can feed my children, not recognizing just how much more expensive it is to not provide those resources and to work on those issues. But it's really easy for us to not care about that community in Kentucky. It's really easy for us to not care about the trans kids and the queer adults that are suffering, because that's not my problem. And there's something else. There's some other group that's dealing with this that doesn't affect me. And so instead of being willing to buy into a system that would overall be cheaper, if we, standardize healthcare, for example, it's overall cheaper to provide food assistance rather than letting all of these, that story about Austin, I bet we could calculate how much money went into caring for someone like that, because he wasn't able to pay his bills, so the hospital has to foot it, and that gets passed on to someone else. The state has to absorb part of it, and then all of the extra pieces around a patient like that end up exponentially being more effective than just providing the services that patient needs. Similar for community, it's so much cheaper to provide some mental health support versus dealing with the ramifications, the cost of a suicide attempt, or the lifelong outcomes that that person suffers because they've been stigmatized and ostracized.
Fantastic. I'll focus on just one aspect of your question, and that would be, we'll focus on the food aspect that you mentioned. So I think we could all agree that everything evolves. I'm not saying everything evolves for the better, but everything evolves. And so you can kind of go back and look at the evolution of food in America. And fast food started in the 1950s. I won't say names of restaurants, we can all name them. These are fast food restaurants. I would like to think these fast food restaurants exist in order to help feed the masses. These fast food restaurants exist to make profit. That's why they exist. And they exist through feeding the masses. They're going to make the food enjoyable, enticing. And we know that food that's high in sugar and high in fat and high in salt are, to our taste buds, delicious. And it's also convenient. And they're smart, they're going to find a price point that even, we'll say, the lowest denominator income can afford. And we've seen more and more fast food just infiltrate even rural areas. My mother lives in a little town called Clintwood, Virginia. Clintwood has a population of about 800. It has one grocery store, but it has about 5 fast food restaurants. And if I go and count the cars at the fast food restaurants, each individual fast food restaurant has more cars than the grocery store. Because the food that we cook at home doesn't taste as good to us as fast food. Plus, it's inconvenient to have to cook at home. It might take a while versus driving through the drive-through. And so it evolves into a taste and convenience, but then again, it becomes unhealthy because it's high in sugars, it's high in fats, it's high in sodium. So our diabetes is out of control, our congestive heart failure is out of control, our blood pressure is out of control. And I'm not blaming the fast food restaurant, but sometimes convenience and what we will call self-gratification through pleasing taste takes priority and is much easier to do than what we call the healthy option. Let's think of healthy options. Cooking and eating wonderful food takes time. Exercise takes time. Cooking and eating is more laborious than driving through a fast food restaurant. Exercise can be very laborious. So the things that we consider good for us require human effort. So things evolve, but not always to our advantage.
So the question is, what are some of the barriers that students might face when engaging or considering pursuing health disparity work? I think that fits with both of you.
That does. You're right.
Go ahead. Go ahead.
All right. So one of the barriers that students may face when considering pursuing health disparity work is just lack of knowing how to do it. You need mentors to show you the way. And finding and engaging those mentors is one of the challenges. Another challenge is believing in yourself. A lot of times, students don't believe that they have the capacity to be a nurse or a doctor. Oh, you got to be real smart to do that. I'm not that smart. And Dr. Fasolino and I were talking about that today. And the answer is, you just have to be smart enough. You don't have to, you don't have to be that smart. And for most students who go to college, the truth is you're smart enough. So believe in yourself. The other is that you think that you can't afford to go to school. But the truth is you cannot afford not to go to school. There's only two things that's worth taking out a loan: your house and school. So do it. And once you get it, there really are no other barriers. They're begging people to come and work in areas that have health disparities.
I'm going to say that probably the biggest barrier that students face is imposter syndrome. It's really themselves. In my work, I have a lab of about 9 postdoctoral fellows at any one time. I'm teaching students here at Clemson, students in the medical school. And the thing I have to constantly remind students when they're terrified because they don't know how to approach something is, well, duh, of course they don't know. It's not the job of the student to know. It's not the job of the student to have the answer. The job of the student, in my opinion, is to ask the question. So if a student is interested in pursuing health disparities research, start asking questions. When you're presented with evidence and someone tells you that African Americans are more likely to get hypertension, just ask why. Poking, digging, looking a little bit deeper, you'll start to uncover these pieces and you'll find that piece that you can do. Education is very, very important. Not all of us need to get a PhD though. Not all of us need to go to medical school. We need people that have bachelor's degrees. We need high school graduates who like to read in these conversations and in this work. Find the level of education that you want to achieve, and then find a way that you can position yourself to start contributing. And just ask the question. Just a few weeks ago, one of my postdocs asked me to sit down and have a call with him. He was completely lost and had no idea what we were doing. It was completely overwhelmed, thought, well, we started the call by him saying, please don't tell, the other supervisors, don't tell our executive director, but I have no idea why we're doing this. He was terrified. And as I started talking to him, started finding out more what he was understanding, I realized we had fundamentally misunderstood a variable we were working with, and he had uncovered it. So his confusion wasn't his fault, it's because we had designed the study wrong. So a learner asking a question is what actually moves a project forward, because by the time you get out, by the time you've completed your training, by the time you're a director, you're kind of set in your ways. I have a way that I approach every problem. And I need someone there to ask a question to help me reframe and rethink how I'm dealing with that. And that's the piece that really opens up. So at the end of the day, I think the biggest barrier is the student themselves. Don't be afraid, don't be shy. Ask why. If you don't understand, there's a good reason why you understand, and it may be because your supervisor actually missed something. So don't be afraid to ask.
Thank you. Well, thank you for those questions. That concludes our conference this evening.